Perfect. So thank you guys all for being here for this learning session. This is kind of wrapping up our first year of this SUD bundle initiative. And we are so glad to have everybody join us today. Thank you for taking the time out of your schedule. I apologize, this has been rescheduled from January, but we've got some really great speakers lined up that I'm really excited about to share with you today. Sorry, I'm just reading through the chat. Suzanne, mud drying up. Yes, that is my backyard right now. And yes, once that's all gone, spring can come. I love it. Oh, sand volleyball. Okay, I want to know where you play, Jacob, because that I'm like looking at a couple leagues this summer. That sounds really fun. Okay, so as everybody joins, add in your name, where you're calling from, and what you're looking forward to this spring, summer. Perfect. And maybe we can get some good warm vibes going and keep this good weather coming. But first up on our agenda, we have Stephanie Hansen. She is our South Dakota lead, our SDSU partner. You guys probably recognize her from our annual meeting that she helped host at SDSU this last year. And she is going to share some lived experience that she has had, and then for our teams that are on the call, I'm just giving you kind of a heads up. We sent an email out earlier this week. We really want to celebrate you guys, so be thinking of some of the wins that you have that you've been able to achieve over this last year of hard work that you and your teams have done. And then we'll have you guys come off of mute if you feel comfortable, after Stephanie is done, and kind of let us celebrate with you all of the great things that are going on. So right now I'm going to let Stephanie come off of mute and share your story.
Hello, everyone. Sorry, I still have a bit of a cold coming and going, and so my voice is not always in, so I'm going to do my best. But yeah, so some of you may have heard this, at least pieces of this story at the annual meeting. So hang in there with me if you've already heard parts of this. But I wanted to come on and share a little bit of my experience that I went through when my second child was born, Brooklyn. And so I had, after I had my son Liam, I'm going to give a little bit of context first, but after I had my son Liam, who was my first child, I developed severe postpartum depression, anxiety, PTSD, and psychosis. And so was put on a bunch of psychiatric medication to get through that and to be able to even get to a point where I could go through talk therapy and discuss what happened and kind of gain perspective and mentally start to heal from that. And so went through several years where I stayed in talk therapy, maintained that medication regimen. And then my husband and I decided that despite all of the trauma and kind of negative experiences that we had with my son, that we wanted to try to have a second child. And so that happened much quicker than we anticipated, which was a good, happy thing, a surprise. But one of the things that we ran into right away was that we had to be self-advocates to be able for me to stay on that medication. And so throughout the pregnancy, I stayed on all of my psychiatric medication, kind of despite some provider pushback of, well, we don't know if it's safe or not. And at the time, I was fortunate enough to have a reproductive psychiatrist who was advising and overseeing that. And was able to interact with those providers. So I stayed on the medication and was able to, at least throughout my pregnancy, be in a good mental space, which was a really good thing because, I was repeatedly told over and over again that a functional mom was more important than, was what was most important, I should say. And so went through pregnancy and then got to 36 weeks and went into labor on my own again. So early for my second pregnancy, not as early as the first time, but early. And had my daughter during COVID. And so Was fortunate again to have a doula the second time. And she was a big advocate for us, and went through delivery. She ended up having to be a C-section following a failed external version, because she was breech and the version just didn't work, which was traumatic. And so went through a series of more birth trauma with her. And then following birth, it very quickly became clear that Brooklyn was going through withdrawal. And I was accused by the medical team of using substances during my pregnancy very quickly, despite clearly stating and having no evidence of use other than Brooklyn's withdrawal symptoms, that I had not done that. And the only thing that I had been taking were my psychiatric medications, prenatal vitamins, like things that I needed to be able to be a functional mom and parent. And so went through a lot of really unfortunate circumstances where the providers didn't believe me. They repeatedly accused me of using substances, illicit substances, not things that were necessary for my own well-being. Um, and went through that repeatedly and really got to a really dark place of shame and guilt and feeling like I shouldn't have been using even my medications, because as a mom, it was hard to see my daughter going through withdrawal and feeling like it was my fault. And in some way, that I should have changed what happened. And so it was really something that I believe now in, retrospect, should not have happened, because it was something that was necessary. And so one of the things that, this bundle implementation, especially in year two, when we start looking at things, and we'll get more into this, but is that one of the things that providers are seeing more of is withdrawal as a result of antidepressant use during pregnancy. And so there's really a need for providers to begin to understand that that can happen, and it doesn't mean that mom is using substances other than antidepressants. And so there's a need for them to understand that that can happen, and for them to understand the impact of accusations of that level for mom, when that's not what's happening. And so just wanted to share a little bit of that experience and put some context into that so others can have the opportunity to hear from someone who had that happen, and to understand that it's not fun either as a mom to see your new infant going through that. She was very jittery, very, she was fine. She just was jittery for about 24 to 36 hours. But because of the way it was framed in the accusations, it brought a lot of guilt and shame to me as mom. And so that's something that then led to or at least partially led to it. I'm not directly linking them, but there was some contribution then to recurrence of severe perinatal depression, anxiety, PTSD, and psychosis again after Brooklyn was born. And so just would encourage providers to be mindful of the framing and the conversations and the way they have those conversations with parents, because it does have an impact, and there's better ways to approach that. So if anybody has any questions about my experience or anything, I'm happy to answer them. Otherwise, I can turn it back over to Morgan.
Thank you so much, Stephanie. If anybody has any questions, go ahead, pop them in the chat or come off of mute. And we will be sharing her email later on too, and she's on our website, and there are other good contact ways if you don't have something you want to come off of mute right now to ask. Stephanie, thank you so much for opening up, being vulnerable, and sharing your story. I know you did it at our annual meeting, and when you shared it, I was like, I'm bookmarking you for a learning session, because I think your experience is so important and need to highlight. I know we've talked a lot about moms that are suffering from substance use disorder, but as we're moving into this next phase with baby, that there is a whole more of a spectrum and care that we need to take when we address this. So thank you, Stephanie. So now kind of moving forward, I want to celebrate you teams and all of the work that you've been doing in your hospitals. Does anybody want to come off of mute and kind of share some of the successes or these wins that you've had over this past year of hard work?
Well, this is Jackie. I can share.
Yes, that would be wonderful.
Okay. I'm in Fargo at Sanford, and one of our wins. So after one of the guest speakers, Christy, came and spoke to this group, she came to one of our staff meetings and shared her perspective and her story, which was really powerful to our team. And shortly after that, there was a family where kind of a similar situation that she had explained in her past, and CPS was involved, and the CPS worker and our social workers commended our staff for the compassionate care that they received and the non-judgmental care, which was something that we were working towards. I know that obviously we still have growth to do, but it just came on the heels after that presentation. So to me, that was a really big win.
Oh, that is wonderful. I am so glad you got Christy. She is amazing. And yeah, I don't know how you could not hear her story and kind of have a paradigm shift of treatment. But
everybody was
I love
crying
that you saw that. Okay. Yeah, she's awesome. Thank you, Jackie. Is there anybody else on here that wants to share from your teams? I know our team in Bismarck Joint Commission finally showed up after a couple months of them waiting on pins and needles, and so they're not able to be here. But in their clinic, they sent me, they were able to implement the 5 Ps, and now they're going through and switching to Epic, and so hopefully they'll be able to keep that work moving forward. But anybody else on here want to come on and let us celebrate with you? Okay, that is okay. If you have some you want to drop in the chat, that would be awesome. Or email them to me, please. I love to hear about all of the work that's going on in your hospitals, and we just want to make sure your efforts are not being recognized. Okay, so next up we have just a little bit of, sorry, I'm trying to get my screens all set here. Our team has been growing on the PQC side, and we are really excited to kind of introduce our new structure and kind of a little bit of what next year is going to look like and some changes that are coming. We've had some incredible opportunities come up over this last year that we were able to get some more funding and add to our team to better support you guys. And so I am going to just hurry and share my screen. Okay, perfect. So this first slide, this presentation is going to be me, Stephanie, and Carrie. You'll meet her in a minute. She is wonderful. And we kind of just want to talk about moving forward with our PQC. Just real quick, our PQC covers both North and South Dakota with some of the funding that is for the PQC wide funding. We are working on tribal outreach and quality improvement initiatives in non-birthing facilities. So that includes clinics, critical access hospitals, anybody that sees prenatal, postpartum, anywhere in that spectrum, but they don't do births. And then our next set of funding that we got really is building out our North and South Dakota teams. The funding is based on state, so we have created 2 focus teams. South Dakota team is led by Stephanie, And then our North Dakota team is going to be led by Ozma. We'll introduce our teams here in just a minute, but these teams are supporting our birthing hospital AIM bundle initiatives. So kind of what we're doing here, if you're South Dakota Hospital, you're going to be talking a lot more to Stephanie and Carrie. They're going to be able to give you that QI data support. They'll be leading the data collection. But we are moving forward together. We've got the same, we're doing our initiatives the same. We're still under this umbrella of the NSDPQC, but there might be a little bit variation in the data collection just because each state is different, and also maybe some of the resources that one state has and another one doesn't. But we are working really closely together to make sure everything is continuous through both states. And just want to make sure that you know, if you hear from our SDSU team, South Dakota team, they're still PQC, we're still working all together. We're just having a couple different names to our roster. So on our NSDPQC staff, that is our executive director, Andrew Williams, myself, Vicki Alberts, who is our tribal liaison, and Erin Kraft, and she's helping us get CME for topic calls for this next year, and hopefully some more trainings and stuff. And then next, we'll introduce our South Dakota team. Stephanie and Carrie, if you guys want to come off, I'll let you guys introduce your team so our South Dakota hospitals can get to know you a little bit more.
Yeah, sure. I can start. I'm Stephanie Hansen. Like Morgan said, I'm the South Dakota lead. Carrie did a good job of pulling some pictures of my kiddos and my family for you all to see. I have two kiddos. Liam is my 6-year-old son that you see. He's a rowdy little guy, super smart.
Hey, Marietta, can I speak to Carol?
Oh. And then Brooklyn is a little girl you see. She's almost 3. She was waving to everybody on camera a little bit ago. She's home from daycare today. So yeah, I am currently getting my PhD in social work, so and focus in perinatal mental health disorders. So as this initiative moves forward, I'm hoping to be able to really plug in when we get to that. But this next year, really excited to be working on the SUD Dyad approach, and we'll talk more about that here in just a few more minutes. And so I'm going to turn it over to Carrie.
And actually, if you want to go to the next slide, Morgan, I'll let you just briefly introduce these two gentlemen, Steph.
Yep. And then we also have 2 other members of our South Dakota team who are not on the call today. But we have Chris Robbins, who's on the left, Dr. Chris Robbins, who's on the left. He is our data specialist for the South Dakota side. He is an absolute whiz at anything data related. And so we've asked him to be a part of the team for supporting hospitals and getting data submitted to AIM and things like that. And then on the right, you see Dr. Jim Amell. He goes by Jim. He has been brought into the project to help with the focus group work that we're going to be doing with parents to better understand their experiences in South Dakota so that we can better implement bundles specific to our state's needs. And so he is wonderful when it comes to qualitative work. And just as, sorry, Brooklyn is kicking my computer at the moment. Just as someone to have a little bit more expertise on our team was willing to come on and really wanted to be supportive of this work. And so we asked him to be part of the team as well. So, all right. And then now I guess I will hand it over to Carrie. Sorry about that.
Perfect. So hello, I'm very excited to be working with all of you over the next 4 years, realistically, hopefully. My name is Carrie. I serve as the community clinic specialist for South Dakota. So that basically means I'm the person who's unfortunately going to be filling your email boxes. I'm trying to be really intentional about that. So that's why you maybe haven't heard from me as much as I would have liked at this point. But yeah, a little bit about me. I'm South Dakota born and raised. I've been here my entire life. So this work is extremely meaningful to me, even though I don't have children at this point, just because this is my home. Like, I am dedicated to improving healthcare here in any way possible. I have both my undergrad and my master's degree from SDSU, so I've never worked quite this closely with North Dakota before. But thankfully, the PQC is based out of UND, not NDSU. Otherwise, there might have been some issues there. All joking aside, like I said, I'm very excited to be working here and helping to improve healthcare in this state. So I look forward to getting to know you all over the next 4 years. And then last but not least, oh, okay, sorry, last but not least, we have Diana, so I'll let her come on and introduce herself.
Hi, I am Diana. I am the student researcher for the South Dakota section of this Birth South Dakota AIM project. I am originally from San Antonio, but I moved up here in 2017, where I did my undergrad at USD, and now I do my I just started my MPH, but I'm doing that through SDSU and USD both. Yeah, I just started this back in November and I'm just super excited. Hopefully I will plan to be here for a long time as well. So I'm really excited just to see where we go with this, and the impact that we make pretty much is super exciting. But yeah, I have a cat. I'm not a mother either yet, but I do have a cat until then, and his name's Owen. It's a little orange guy in the corner. He's really awesome. He takes up a lot of my time. So yeah.
Okay, and then I think we can turn it back to you, Morgan. Thank you.
Perfect. Thank you. As you can see, we've got an awesome South Dakota team that we are building out, and our North Dakota team is in the process of building right now. We have Ozma. She's on. Ozma, if you want to come on and introduce yourself, I would love that if you can come off of mute. She is like just hired. Like, she's starting in 2 weeks. We are so excited she's on our team. I know she was
Hi,
on.
everyone.
Oh, there you are. Okay, great. Yes, Ozma, do you want to introduce yourself a little bit to everybody?
Yeah, sure. Thank you, Morgan. Hi, everyone. My name is Asmal Husna, and I'll be joining as ND Hospital Coordinator very soon. I'm really excited. A few things about myself. I am originally hailed from Bangladesh. I completed my undergrad from there, and then following my completion of undergrad, I had the privilege to work with a project that has focused on improving maternal and child health in Bangladesh, and that their responsibilities almost aligns with NSDPQC, improving prenatal health care. And I earned my master's from UND last year, specializing in health management policy, and also get to work as research assistant last summer with NSDPQC. And it's a lovely weather today. I'm living in Grand Forks for the last 3 years. February is always gloomy and cloudy, but it's sunny today. It's beautiful out there. And as you can see in my photos, on the left one, I'm wearing sari. It's a traditional wear for Bangladeshi women, and it's a 6-meter cloth you have to wrap around. And I love to wear sari, so whenever I got any opportunity or occasion, I'll wear sari. Sometimes I wear sari at home too. And I'm excited to getting to know each one of you and working closely. And yeah, thank you.
Perfect. Thanks, Ozma. North Dakota hospitals, be on the lookout. I'll be sending emails introducing you to Ozma once she is fully onboarded and starting. She was sweet enough to join, even though we don't have, like, her start date isn't yet, but 2 weeks and we get her full time, which is so exciting because as our teams grow, that's just even more support and help that we can give to you guys. So moving forward together, we've got some really great resources that are on our side. We've got our consultant, Amy Ladley. I know a lot of you guys have already met her, and we're going to hear from her in just a few minutes. She is wonderful and amazing. She's here to help our PQC grow with our capacity and be strategic in how our teams are growing, but also to help support hospitals. As our PQC is connected through HRSA grants and CDC funding, we are also part of this national network of PQCs. So we have even more resources to reach out to and learn from to bring back to our states here. We've got this IHI Breakthrough Series that our PQC staff, some of our staff are going to and going through this training that is just going to even help us more support you better and run these initiatives more successfully, I think. And then we also have IHI Open School that I did send an email to our day-to-day leads about a month ago. If you haven't seen it, please go search for emails from me in January. This is a really amazing opportunity. We, as the PQC, bought like a block of licenses. And so each hospital, we've given you an access code. You can have 2 logins with that access code and be able to get all of these quality improvement trainings, patient safety. They have just like a whole range of amazing trainings and videos and things to watch to help you in your hospitals do this work more efficiently. So please, if you haven't looked at that, this is my shameless plug of please go look at it, use it. We had purchased it with the intention of just being able to give you guys more educational resources. And I think it's something that we're going to try to keep in our budget that we can just renew every year and have as an offering. Really quick, I'm just going to be a little speedy. Moving forward, looking into 2024, I know last year when we were talking about these projects, we kind of talked about, okay, we're doing maternal focus 1 year, infant focus year 2. As our teams have grown and kind of our vision has shifted a little bit, we are gonna, instead of just focusing on baby, it's going to be the focus on the dyad. So our maternal work is not done yet. Like, you guys are off the hook. We're still working hard. We're still going to be working through PDSA cycles and data collection, even though the data collection this year is going to change a little bit. Another plug, be ready to hear from myself, Asma, and Carrie. We want feedback on some of these new data collection tools we're putting together, and hopefully we can find a process that works well for you and for us, and that we can have some really successful data collection over this next year. And then we are beginning our infant work. We want to work with our well baby units and nurseries. We want to work in our NICUs. I know some of your teams have already expanded. Please send me contact information for those new team members, just so I can make sure that they're on our emails and our invites for meetings and other updates through the PQC. But then we'll also be working with PDSA cycles and data collection on that infant side as well. And so we are, we're all continuing our work. Like, we're not forgetting about moms. We are working with everybody. We are updating core documents like our driver diagram and our change package. As our team has grown, we've had more eyes on it, trying to figure out how to make it a little bit more accessible and not as scary, easier to read, and something that we can follow along and really build off of for this year. And so as we have these finalized, I mean, we have been going through drafts and drafts and drafts to make this as refined and perfect as possible for you guys. And we are really wanting to pull in some more resources and education and finalizing this data collection piece as well. Last thing, we have a poll from Carrie. I'm going to let her jump on and kind of explain this, but please use your phones.
Yes, or if you don't want to use your phones, I will drop a link in the chat. I'm sorry, I should have been more prepared for this. But as Morgan said, now that we're growing and we're just trying to figure out how we can best serve you, how we can make just this quality improvement work easier to access, essentially. So please, if you have a couple of minutes right now, pull out your phone, scan that QR code, or I just dropped a link in the chat. You can copy and paste that directly into your browser. We have a 4-question survey for you today to help us figure out how we can best improve data collection and things like that. So take a couple of minutes, please feel free to send me a private chat or a group chat if you're having any issues with it. This is technology that we're hoping to bring into these learning sessions more often. So this is also a little bit of a dry run to see how this works. Okay, so I will be quiet, but please let me know
There
if
are
you
our own
need any help.
PDSA cycles, Carrie. We're doing our own PDSA cycles over here.
Right, and it's working, so.
It is.
Oh, and I forgot to mention, you shouldn't have to put in your name or anything. I made this anonymous intentionally because I'm asking questions like, what are your biggest barriers to data collection? And what can we do to support you? So feel free to be completely upfront with us because that's how we can make the most effective changes. So you shouldn't need to put your name in there. And even if you did put your name in there because you already have a Poll Everywhere account, I won't be able to see that information on my end. So completely anonymous, let us have it.
Are we getting some responses? Perfect. Okay, so my last shameless plug, our annual meeting, we have scheduled it. It's on the calendar for September 30th to October 1st. It's a Monday, Tuesday. It's going to be in Bismarck this year. Please mark your calendars. If you are planning on attending or probably attending, please RSVP with this QR code. This was emailed out last week, but mark your calendars. We want to have the best turnout we've had this year. We're going to have some travel assistance available, but please just mark your calendars, mark those days off, plan to come be with us in Bismarck. And that is the end of our kind of updates on the PQC side. And next we have our wonderful Amy Ladley. You guys are going to just realize why we love her so much and appreciate all of her hard work. And so Amy, if you want to hop on, I will mute myself and we can just soak up all of this knowledge from you.
Awesome. Thanks, Morgan. Can you enable screen sharing? Awesome. Thank you. And if, obviously, if you can't see it, just let me know if it's the wrong screen or something. But so today I want to, can you see the right screen? Okay, good. Let me just make sure you don't see my lunatic notes. But so today I want to talk a little bit about the Q in PQC. I think to kind of reset our collective knowledge about what this work kind of entails and what's at the core of perinatal quality collaborative work and why it's really important. It's really good that Morgan previewed things like change packages and measurement strategies and PDSAs and all of that, because that's what I'm going to talk about today, is how all of that stuff fits into our work. It's a really good way to connect what Morgan just talked about and all the stuff that you're going to be receiving from the team in the coming weeks related to this work. So let's see if we can get this rolling. Just anybody want to function? There we go. Okay, so I really want to talk about why perinatal quality collaboratives are important. I'm going to talk about systematic change, and why it's so important for things like buy-in and sustainability. And then I'm also going to talk about the model for improvement, which is sort of how this work is like the foundation of this work. I know we've all, listen, like if you worked in like a clinical setting, you have been like bonked over the head with like Lean Six Sigma, somebody's project, whether it's like an administrator or a doctor. We're going to go back to the model for improvement because I think it's quite frankly more fun. So PQCs are really, really great. Every state in the country has one. They're all organized a little bit differently, but what we know is that they're successful. They work. We know that they are effective when it comes to things like hemorrhage and hypertension response, and birth certificate accuracy, right? That's like a weird small one, but it's super important, right? Making sure your birth certificates are accurate. That was a project from Alabama. NTSV and early elective deliveries, successful with both of those. So if you speak Joint Commission, that's PCO1 and PCO2. Things like average length of stay and scheduled therapies for substance exposed newborns, which is kind of where we are now. So we know that other states have been really successful doing perinatal quality collaborative work related to what y'all are working on now, which is really amazing. Colorado's done a great job. Illinois, Massachusetts, other states have done exceptional work in this area that we're kind of in the middle of here in North and South Dakota, which is awesome. And also improving disparities, racial and ethnic disparities in health outcomes. So we know that perinatal quality collaboratives are really, really effective in kind of improving outcomes for dyads and for families. But why do we why do we approach it in a systematic way? Why don't we just fix our policies, everybody do what they're supposed to do, and things are better? Because one, that's not realistic. That's not how things work in the real world. But two, systematic change is really important, right? This process of improvement science is really not just about the changes you're trying to make, but how you most effectively make change. It's about learning how we work and learning how we work together so we can do it easier next time. And that's why this is so, so important, this method that we're kind of leaning into here for our PQC work. So improvement science has kind of 6 core ideas that I really like, and I'm not going to talk about all of these forever because that's like a presentation in and of itself. But I think it's really important to know this idea of specificity, right? We're trying to solve something very precise, and we're trying to address variation within that. So if you think about how we do our work on a daily basis, whether that's in a NICU or on labor and delivery or in an outpatient setting, right? In general, the work is all headed in one direction, but there's a lot of variation between individuals that work within that system, right? And what we're trying to minimize and address is variation that leads to outcomes that aren't ideal. So we really want to know kind of what works for whom and under what circumstances, and building systems that produce better outcomes. I think it's really important, Carrie talked about this, Morgan talked about this, but measurement is so important, and I'm going to talk more about it in a few minutes. But we measure from the beginning and we measure often. You don't measure halfway through your work. You start at the beginning so you know how much you've improved, and so you can tell the story of your work. I think if you work in hospitals and you work with physicians, being able to apply some numeracy to your work is so, so important. So measurement is of the utmost importance when you're talking about improvement science. You have to be disciplined in your inquiry, right? And that means that you have to really follow those procedures of how we approach solving this problem. And that means we really have to learn how to fail. Quality improvement is really about making the most of your failure, and failure is good, right? We want failure because that's how we learn in quality improvement. And so this is a really great place. This perinatal quality collaborative work is a really great place to not be right the first time. And that is so antithetical to kind of how we operate in clinical settings. I worked in a pediatric hospital for 5.5 years, right? So you think if I don't get it right the first time, something really bad's going to happen. But the truth is, the way we build quality improvement and build our work is so we aren't starting to fix the thing that can cause the bad thing to happen, right? We're starting kind of a little bit lower stakes. We're refining our process, and we learn to fail, and we fail fast because we aren't doing tests that take 2, 3, 4 months or years, right? A test, a PDSA, and I'm going to talk about this in a second, can one patient, one time. That's a PDSA. One patient, one time. And you're going to learn a lot, right? If you approach it correctly. And also we accelerate improvement through collaboration. I think the wisdom of crowds is really important, particularly for this dyadic SUD work. You need a multidisciplinary team. It can't just be like the one nurse who does everything. Y'all know her. And I know some of y'all in this meeting, some of you all are her. Some of you all are that nurse. But we need multidisciplinary teams because those other ideas and other perspectives are so important for us in refining our process and helping us move through this. So I'm going to talk about the model for improvement because I love it. I love it. It's not that I don't love Lean or Six Sigma or Kaizen or all those other things. I like the model for improvement because it really allows us to choose our own adventure. It is not as exclusively married to like a form, a structure, a table, a thing you fill out. It is a little bit more organic, which I think works well in like hospital settings where there's a lot going on. It also is not as focused on efficiency. When I say efficiency, I mean money, like Lean and Six Sigma and some others are, right? So I think the model for improvement is amazing. And if there is like a chat that I question, just somebody shout it out.
Amy, don't worry, it's just me making comments. So
awesome. Okay. I hope they are flattering, Andrew. Okay. So here's the model for improvement. It's like so easy. And we're going to talk about each part of this. Sort of the top are 3 fundamental questions that we're asking ourselves, right, when doing improvement work. And at the bottom is something I'm sure you all are familiar with. Some of you might be a little triggered, but it's okay. We're going to get through this together. Is a PDSA cycle, which is the engine of this work. So we're going to do a deep dive into each of these parts together. And it's going to be amazing. And you guys are going to all be on the model for improvement bus with me by the end of this. So what are we trying to accomplish? This is our North Star, right? And we need to know a very clear idea of what we want to accomplish before we get rolling. Because otherwise you're just sort of like meandering through kind of like the pile of improvement that needs to happen. And that's like everything, right? So we really need a North Star, and it is not just about making plans, like how do we get there? What's our roadmap to get to our North Star? But also, how do we allocate resources? How many people do we need? How much money do we need? Do we need new supplies? Do we finally have to have that awful conversation with the people in the lab who hate us, right? Or the blood bank? Those are all things that we need to address when we come up with our North Star. I know a lot of you have heard about SMART aims because I think they're everywhere, right? I do some Greek life advising on the side, and I was like looking through something and they're like, we want the chapter to develop SMART aims. And I was like, no, SMART aims are terrible. I like aims that are fast. Those are aims that are frequently discussed. So we're revisiting our aim, our North Star all the time. Where are we in relation to the North Star? They're ambitious, so they're just out of reach. They are specific. I think sometimes SMART aims can be a little namby-pamby and a little wishy-washy. We don't do that here. Specific aims, and they're transparent. They're something that everybody knows and can get behind. So I love a fast aim, not a SMART aim. As you can tell, I'm super speedy this morning. So I'm living my best aim self. So that's what we're trying to accomplish. I will say, though, that Morgan and the rest of the NSDPQC team, they're going to share with you the aim for this next year of work, right? They're going to share with you the North Star for the collaborative. And I think that's really important. They're being transparent, right? That's super great. But I think as a hospital, right, as a facility, as a site doing this work, come up with your own aim, right? Think about, okay, so this is what we are contributing to in relation to the collaborative, but here's what we want to accomplish where we are relative to this work. I think that's super important. Was change and improvement. And this is where we talk about measurement, right? A measurement strategy lets you know if you've achieved your aim. The only way to know if you've actually gotten there is to measure. So important. And measurement strategy is not about just what you're measuring, but like when, how often, how you're operationalizing it. If I say, you know, like, okay, we all know about like Joint Commission and like breastfeeding measures, right? There's a difference between initiation and exclusivity, right? So we could just say like, is that parent breastfeeding? And we need to know like how are we defining that, right? Because initiation is different than exclusivity. And those two definitions make a difference when you're talking about a parent who maybe breastfed once, wasn't successful, it wasn't for them, or it wasn't something they wanted to do. And that parent who's like my good friend, Elizabeth, who breastfed, like basically really until the kid was like, we can't do this anymore. I got stuff to do. There are Legos to play with. So measurement's really important. And when we talk about measurement, we could measure everything, right? And sometimes it feels like at the hospital level, like that's what they want us to do is measure everything. But I think usefulness is more than perfection here when we talk about measurement. We want our measures to be useful, to be explanatory, to help us tell a story. They don't need to be perfect. They just need to be useful in helping us explain what we're doing and how close we're getting to our North Star. We really want to focus on improvement, not just measuring for the sake of measuring, in which case we need to measure just enough data, right? We don't want to kitchen sink it, right? We don't need to throw all the measures in there, only the measures we need to tell the story about whether or not we made it to our goal. That's the important thing. Common types of measures, I feel like some of you might have like an eye twitch if you had to learn this in school, but these are kind of the most important measures you're going to see in PQCs. Outcome, process, structure, and balancing measures are all really important in there. And because I think some of you, I might lose some of you if I go into detail. I won't tell you, but I can give you examples. So if we want to talk about it, let me know. So what change leads to an improvement? This is like the last question in that top section, the 3 questions. So like how do we improve? And this is where Morgan mentioned drivers and change ideas and a change package. This really kind of gets to that, right? Primary drivers are those key areas of influence you need to push in order to get to your aim. And then you have secondary drivers, which are kind of aspects of those primary drivers. And then you have those testable changes, concrete testable changes grounded in evidence that push you to, right, that push you through those drivers and help you achieve your aim. And this is just another way to kind of think about it, right? Is that they kind of all fall, right? The aim starts and then you move through. So back to the model for improvement. What are we trying to accomplish? That's our aim. That's our North Star, right? And you're going to get this from the NSDPQC team for this next phase of this work. How do we know changes and improvement? Well, we have to measure it. And they're going to give you measurement, which is really great and amazing. Carrie's been asking questions about measurement today in the poll. So we're going to talk about measurement together, and they're going to help you. And then what change can we make that will result in improvement? We get that from our drivers and our changes in our change package. So that's kind of how the model for improvement is fitting into what's coming up for y'all. But now let's talk about PDSAs because they're my favorite thing ever. I've done this work with other states, but I have one very clear picture of a conversation with a nurse, very experienced, seasoned nurse in rural Louisiana who was like, I can't do a PDSA. I can't. I don't understand them. I don't get it. I think they're crazy. I can't figure it out. And I was like, girl, your entire life as a nurse leader has been about PDSAing. You just don't know it. And once we switched her thinking about it, right, everything changed. And she became the most PDSA rock star ever. Patsy should be giving you this talk, but she's probably delivering a baby. So can't do that. So why do we test change? This is like, IHI says this a lot, and I think it's so perfect, is that not every change results in an improvement, but all improvement requires change. If you want to get better, something has to change. And like, if you are in any kind of like health journey or anything else, Like this applies to our private lives as well as our professional ones, right? So not every change results in improvement, but all improvement requires change. And PDSAs are one way to do that. And PDSAs apply to not just like PQC work, but everything. You can PDSA potty training your dog. Facts. Testing is good because like we can evaluate, right, all of these things that occur around the change, right? What are side effects of change? How do people respond to change? It helps us know what's best in our environment or our system. It eases transition and silences critics. This is such an important one. Like if you have if you have somebody on your team, right, who is like, this will never work, or what we do is fine, we don't need to change anything, you start with what they hate most. And that is the change you work on first, because it helps silence critics, right? It engages them and helps silence its critics. And the truth is you're already doing it. Remember I talked about Patsy in Louisiana. You are all nurses, right? And people in healthcare settings are natural improvement scientists. You are constantly figuring out how to like solve the problem to help your patient. You are already doing it. You're just not doing it in a systematic way. You are like solving the problem and then moving on to the next crisis. You are already doing improvement science. You're just not formalizing it under the banner of PDSA. And once you kind of make that shift to capturing it and formalizing it, you are going to be in great shape. So like this is a really good, I think if we could go into more detail, but probably not, but this is a good slide to kind of think about, right? Planning is about like, what do we try? Who, what, when, where, why, right? Doing is about like actually executing your test. Again, remember, a test doesn't have to be all your patients for 4 months, right? That feels more like implementation to me. That doesn't feel like a PDSA. A PDSA can be one patient, one time, which is amazing. Study, kind of analyze what you've learned, and then act. And then act is really important because you have to do one of 3 things. You have to abandon it, say, wow, that idea was terrible, and we're never doing that again, right? We almost set the unit on fire, right? Whether it's literally or figuratively. We're never doing that again because my tires have been slashed, and so they're expensive. You want to adapt it. So maybe it kind of worked, but we know it could work better because we learned something. So we're going to tweak it and test it again. Or we're going to adopt it because it was awesome. And that was amazing. So this cycle is really, really important. And it doesn't have to be super crazy, right? You can approach it like this idea of like, what if we try? If
Hey.
I talk to people at hospitals, I will ask them, they'll be like, how we don't have any ideas for PDSAs.
Yeah.
We don't know what to work on. We don't know what to do. And I was like, well, how many times in the last 2 weeks has somebody on your staff or your leadership team said, what if we try, or something similar? And they're like, at least 4 times a day. And I'm like, okay, each one of those is potentially an idea for a PDSA. So what if we try, right? That's a big one. So where do you start if you're like, oh, PDSA is like, I don't know where to start. So much needs to be changed. Like, how do I fix it? So you have a couple approaches. You go like, where do you get a quick win to kind of start getting people like interested in change? Thinking about things that are already working but could work better, right? So we're not starting at like 0, we're starting at like a 5. And what do you have to fix now? What is so urgent, right? Or so non-functional that it needs to be addressed. And test size matters when you're starting a PDSA. You don't want to start super big. Remember I said 1 patient, 1 time is a PDSA. It helps you build confidence. It helps you manage the cost of failure. And also determine your level of readiness and interest. And I think there's this great table, and this is the last thing I'm going to talk about today, is this table, which I love. I love this table so much. I love it so much because it is so important and so helpful. So how big is your PDSA? Are we in like 1 patient, 1 time territory, or can we try this for a couple weeks and see what's working? And it really is about assessing the level of resistance or readiness, and then confidence and cost. So is the confidence in the change like low? Like, we do not think this is a terrible idea, right? If you have somebody, like if you have that one person on your staff who like tells it like it is, and they're like, I think we do not need to try this. This is terrible. That is low confidence, right? So we already kind of know where we're operating. Or is everybody like, oh my gosh, no, we've been wanting to change this forever. This is a really good idea. Let's see how it works. That's high confidence. We love that. And then is the cost of failure high or low? When I say cost, I don't just mean like monetary cost, right? We don't want to like buy the like, you know, the super expensive Cadillac of hemorrhage carts, like the ones that like sing and talk to you and like do their own math and things like that. If you don't know, like that's a lot of money, right? You don't want to like ask for a ton of money. So money is one part of it, but cost could also be like your reputation, your social and political capital in making change. So if you're the cost, if you're like giving away a lot of your capital in leading this work, that's a lot. It's a really high cost. So you need to start very small. And then we're talking about resistance and readiness. All right, talked about resistance before, but like if you have people who are like, no, change is terrible, everything we're doing is fine, that's high resistance. But if you have people who are like, yeah, we just have never had a roadmap for how to make this work and make this better, that's readiness. And then if you have people in the middle that are like, honestly, like I'm here for 12 hours and I just don't want to get yelled at, you know, like that could be your indifference, right? If we are all tired, then you're in that middle category, right? That's indifference. And then you can start your test very small, large, and then implementing when you know that all of these other pieces are in place. And this is my last slide. I am happy to answer questions, or if we all need to take a collective breath because I've been talking at 100 words per second. That's fine too, but that's it. That's all I've got. I just wanted to ground us again in quality improvement and how that kind of is the engine that moves this work forward, but also connect it to some of the concepts that Morgan and Carrie talked about, and all of the stuff that you're going to be getting in your inboxes over the next couple months relative to this work. So I'm really grateful for this opportunity for all of us to go on this wild quality improvement ride together. All right, back to you, Morgan.
Thank you, Amy. You're awesome. I appreciate you so much. And I hope everybody, like, you're just infectious and your excitement about quality improvement is contagious. And
you're all ready to like Kool-Aid man through a wall and do a PDSA. That was my goal.
We might have to build a Kool-Aid wall at our annual meeting or something. Awesome. Does anybody have any questions for Amy? Awesome. Well, I am really excited to introduce our next speaker. We have Dr. Marcella Smid with us today. She has come highly recommended from multiple people in our PQC, and thanks to the Opioid Response Network, we were able to align our schedules and be able to have her here with us today. She is a board-certified maternal fetal medicine and addiction medicine physician and assistant professor at the University of Utah, my home state. So that's awesome. She is the medical director of the Substance Use and Pregnancy Recovery Addiction Dependence Specialty Prenatal Clinic and a multidisciplinary clinic for pregnant and postpartum individuals with substance use disorder. Her research focuses on perinatal addiction interventions for pregnant and postpartum individuals with substance use disorders, maternal mortality, and maternal mental health. So Dr. Smith, thank you so much for being here. I am so excited to have you. And I will just turn the time right over to you.
Hey, great. Okay, I'm gonna share. Don't judge my screen my desktop too much. Hold on. Here we go. We're getting there. Okay. Okay, great. I can't see the chat, so please, like, if there are questions, I
will monitor the chat for you, and then do you want them at the end or as they come in?
I mean, I think because the reality of the world is that we're all multitasking when we're on these virtual things, and so you may get pulled into something else. Please, we can just do it right at that time. I think it helps. I think. Perfect. Okay, I have full disclosure, way too many slides. So we're going to get through what we can get through, and we'll go from there. And then my good friend Justin is on, and he will see some slides that are 100% lifted from him. So here we go. Okay, so here are my disclosures. The most important one is that if you send me something and it's in Calibri, I will change it to Arial. Okay, so I'm also not a neurobiologist, but I do like to, from a and the intro was perfect because I think it's important to sort of situate perinatal addiction into like how I got into this. And the reason I put this up here is because I sort of fell into it, right? So this is not a talk about me, it's about methamphetamines and our perinatal the way that we consider it, particularly in the Dakotas, where this is a major problem for you guys, as it is here in Utah. But I want to situate perinatal addiction as really an emerging field that I did not think I was going to go into. I did my residency in Chicago, where I never saw methamphetamine. I saw crack cocaine because I trained on the south side of Chicago. Then I did my fellowship at UNC, where there was an integrated clinic that was primarily looking at taking care of women with opioid use disorder. And I really focused on obesity and bariatric surgery. And then I came to the University of Utah, and I was the only person in our department that had an X waiver. And so my clinic became the clinic that people who needed buprenorphine went to. And so I really leaned into that and formed with this lovely human, Jasmine Charles, who's my PA and my co-conspirator in all things, and really did the addiction boards through the clinical pathway. So I haven't done a fellowship. I really did it kind of like on the job training. And then recently I took over as the chair of the Utah Maternal Mortality Review Committee. And I have an interest in MMRCs, particularly because drug-induced deaths are really one of our leading causes of mortality. So that's from me. So none of this is perfect, but that's okay because this is the world that we live in. Also, my love language is certainly memes and GIFs. So you're going to see this presentation replete with those. So I'm going to talk a lot about the words that we use, trajectory of substance use and substance use disorders, and how those intersect with pregnancy and the postpartum period, particularly as it relates to increased morbidity and mortality as you are the PQC, right? This is the whole point of PQCs, is for us to optimize well-being and reduce risk. And then we'll talk about some evidence-informed treatments for methamphetamine use disorder for pregnant and postpartum people. Really importantly, I want to emphasize evidence-informed. In the perinatal addiction world, we very rarely live in an evidence-based world. We have evidence-informed. We use a lot of data from studies that have nothing to do with pregnant and postpartum people, and we extrapolate because it is very difficult to do studies with pregnant and postpartum people in general. The pay line for NICHD is the lowest of all of the NIH sections. So it's really just an uphill struggle, but I am hopeful that we are going to see more evidence-based treatments and I will hopefully end on a note of hope for us. Okay, so words are important, super, super important. This is a talk about methamphetamine. So we're going to start with stigma, because stigma and discrimination really define the experience for many people with methamphetamine use disorder, and pregnant and postpartum people really get a double whammy. So health-related stigma describes the socio-cultural process in which social groups are devalued, rejected, and excluded on the basis of socially discredited health conditions. So really importantly, I'm going to approach this as substance use disorder is a health condition, just like diabetes, just like chronic hypertension. And I really encourage us to approach it as such, because it gives us the tools to truly, I think medicalizing it allows us to help to at least try to destigmatize it as a moral failure as opposed to a medical condition. And so substance use disorders really are some of the most stigmatized health conditions in the world. And pregnant and parenting people really are stigmatized for their condition. And then particularly if they belong to a historically marginalized group, they get a triple whammy. So what is discrimination? Discrimination is the differential treatment based on a set of characteristics, and the experiences of discrimination changes health-related experiences. So this is a quote from one of my patients who said, "I'll never go back to that hospital. I waited until," sorry, I can see you guys, so I have to move you guys. "I waited until I was so sick, I was actually scared I would die. And I had been there before, and they just looked at me like I was trash. They told me I had an infection in my heart, and they told me it was my fault for using IV drugs. I've never been back there." Right. So this is, I think, this is one patient's experience, but I think really characterizes the experience of a lot of people with any kind of substance use disorder, particularly this person had methamphetamine use disorder. And the act of presenting to a healthcare environment is so stigmatizing that people wait a really long time, especially if they're pregnant. We'll talk about some of the reasons that is. Okay, so this is terrible. How can you help, right? So one of the small things that really, really makes an impact is making sure that we're using person-centered, non-stigmatizing language in all the ways that we talk about substance use disorder, even especially as we think about, right, PQCs. You guys are the public health arms, right? Like, you are doing the work. And so when we're using words, that is an intervention that really helps to humanize and to medicalize this condition. So when I say substance use, what do I mean? I mean, it's the sporadic consumption, generally without adverse consequences, of substance use. So, there are 40 some odd people on this talk. I'm not asking you, but if we did the little anonymous poll, right, almost all of you will have used some psychoactive substance in your life, right? It does not mean that you have a substance use disorder. Misuse is the excessive use of psychoactive substances, including alcohol, pain medications, or illegal drugs, potentially leading to physical and social and emotional harm. So if you have had a hangover, you have misused alcohol. So again, if I polled you guys, right, you probably have misused a substance. I'm not asking you for disclosure. I'm just having you reflect upon this. And really a pattern of repeated misuse is we are starting to think about this as pre-addiction. So like we think about pre-diabetes, your hemoglobin A1C is a little bit elevated. It's portending potentially the development of diabetes. Repeated misuse can really portend the development of an addiction. And what do I mean by addiction? So addiction is a primary chronic disease of the brain, of the reward, motivation, memory, and related circuitry. And the dysfunction in these circuits leads to the characteristic biological, psychological, social, and spiritual manifestation. So really importantly, it's not a moral failing, right? It's a chronic disease that requires medical and professional help. And 50% is thought to be hereditary or familial. And this used to say genetic, but it really is probably more complicated than that. So if you took the pedigree of somebody with heart disease, right, you're going to see multiple generations back, people with heart disease. If you take the pedigree of somebody with an addiction, it may not be the same substance, but likely they have multiple generations back of substance use disorders or misuse. And there may be a genetic predisposition. There may be epigenetic changes if there is perinatal addiction use. And the way I think about epigenetic changes is the genetics is the blueprint for your house. So if you drive into a subdivision and the houses all look, right, kind of the same structure, that's your genetics, but your epigenetics is your interior design, right? Every house is going to look a little bit differently based on the experiences of that individual and their interaction with their environment. And then really environmental and the family you're raised in, the environment that you're raised in, the stresses that you encounter. We know that, for example, military service is a really high risk of development of a substance use disorder. So those are all experiences that can really impact whether or not someone develops an addiction or not, and then what the resources are in their environment to be able to help mitigate the stresses that they're experiencing. So how is that different than a substance use disorder? So substance use disorder is how we define, right? This is the DSM-5 criteria of how we actually define these substance use disorder. So, for this is meth. We're going to focus on meth use disorder. So we're going to place meth here. And we'll say it's defined as 2 or more symptoms in the past year resulting in stress or impairment, right? Distress or impairment. So that is actually the really important key here, is that it's not just use, it has to be causing distress or impairment. And so some of those may be unfulfilled work obligations, medical problems. And Mishka Turpelin gives a really great talk. He's an OBGYN who's also an addiction medicine specialist. And he says in pregnancy, and we'll talk about that a little bit as the trajectory, if you're using by the second trimester, it's really pathognomonic of a use disorder, because pregnant people know that use in pregnancy is not ideal. So really that once you're seeing the trajectory of pregnancy and a substance use disorder cross, just because they stop use doesn't mean the substance use disorder is no longer there. And that's really important as we think about how we approach this in order to improve wellness and to mitigate risk. Really importantly, infants cannot have an addiction. This is what happens to my brain when I see people say addicted babies. Babies can have neonatal abstinence syndrome. They can have neonatal opioid withdrawal syndrome if there's exposure to opioids, which is really characteristic of prenatal exposure. They may have withdrawal symptoms, but they cannot be addicted. So using those words really stigmatizes the condition because it uses it inappropriately. So another thing I really encourage people is just to remove that from your lexicon. And then finally, changing your words to person-centered language. So clean and dirty is the one that I see all the time. So these are don't use, do use. So addict, I would say like, should probably just not be a word that we use, right? So person who uses drug, person with a methamphetamine use disorder. Clean and dirty, I see all the time. It drives me bananas when my resident, like I'm like constantly editing their H&Ps when they write them. Even if a person says they got, right, it's different if somebody says, well, I've been clean for 5 years. People can define themselves however they want. But when we're talking about it from a public health perspective or a medical perspective, we want to use in remission, has not used in so much time. Clean or dirty urine, right? So if you say somebody has a clean urine or a clean cord tox, right, you are implying that people that use drugs are dirty, right? So we want to really change this language. And these are the seemingly small, but hugely impactful ways that we can change the discourse around substance use disorders. And that really, I think, will help people engage, both people who are suffering from these conditions and also people who are taking care of people with these conditions. Okay, so we are going to switch to pregnancy and addiction. So what happens when, and this is really substance use in pregnancy in general, there is less data specifically on individuals with meth use, but I can tell you that this is the experience of, in my clinic as well in my experience. So the vast majority of pregnant people will achieve abstinence from substances by the end of the second trimester, and most frequently without any medical intervention. And it doesn't mean that if they have a substance use disorder, that substance use disorder magically disappeared. It's that there's social pressures, but also likely biological underpinnings that I'm going to talk about in just a second that help pregnant people kind of achieve, for the most part, their goal of either decreasing use or stopping altogether. But this is the flip side of this in the postpartum period. 80% of postpartum people who are abstinent in their last month of pregnancy have a return to use of at least one substance postpartum. So really high. So people achieve abstinence if that is their goal most often in pregnancy, or at the very least reduce use, but that risk of return to use in that postpartum period is extremely high. And so why? This is a very busy slide, but I will summarize it, that it may come down to hormones, right? So there are fluctuations in hormones, and I'll use women here, people who are born with XX chromosomes and that have ovaries and produce progesterone and estrogen. And some of these fluctuations may actually place women at risk for addiction. So there's a process called telescoping, where women when women are exposed to a substance, they go from first use to really addiction in a much shorter period of time. And there's increased return to use after periods of abstinence. And that may be because of the balance of estrogen and progesterone. So we're going to go back to high school biology here. So the luteal phase of the menstrual cycle, when you've ovulated, you have high progesterone levels. It's less likely to exhibit addictive behaviors compared to women in the follicular phase, which is in the first part of the cycle, where you have relatively low progesterone levels. And periods of high progesterone, such as pregnancy, there's reduced cravings, and periods of low progesterone, the postpartum period, increased risk of return to use. So there may be some really important biological underpinnings. At the very end of this talk, hopefully we'll get there, I'll talk about a study that we're conducting here at Utah about prevention of return to methamphetamine use for women in the postpartum period, and it's based on these trials. So if you want some really good late night reading, I suggest reading these trials that show that progesterone may actually be helpful in preventing return to use. And so that's really what that is talking about. Okay, so now let's talk about meth, baby. All right, okay. I know you guys know this in the Dakotas, right? So we're in a massive overdose epidemic. We've gotten lots of information and lots of media coverage about opioids and fentanyl, but we are also in a methamphetamine and cocaine epidemic. So the rise of overdoses from methamphetamines and cocaine are increasing. And the slide on the right, you see that really the COVID didn't help a lot of things, and certainly not this pandemic. So we really saw an uptick during the COVID pandemic of increases in methamphetamine related overdoses. And we're kind of plateauing now, but really we haven't recovered to the rates that we saw pre-pandemic. And so this is also in relation to the fentanyl epidemic, right? So we're seeing both. So that light blue line is synthetic opioids other than methadone, which is really primarily fentanyl, and that gray line is psychostimulants. So we were seeing this pre-pandemic as well. So this is really about what's the difference between methamphetamine and cocaine. I think what's important here is to realize that methamphetamine has a much longer half-life. So it takes 50% of the drug is removed from the body in 12 hours for methamphetamine, versus for cocaine, it's about an hour. Right. And so when you are the difference between meth and cocaine is that methamphetamine increases both the dopamine release, but it also blocks dopamine reuptake, and cocaine blocks dopamine reuptake. One of the best ways I've heard this described is, Matt, I want everybody here to imagine the best orgasm of your life, right? So like go to that place. Now imagine that. Now that's the amount of dopamine that was released along with other hormones, including oxytocin, my favorite as an OB, right? Now, methamphetamine, double that, right? So there's nothing natural that you can do that actually is better than the first time that someone experiences methamphetamine. So it's really that chasing that dragon that we get into the cycle of use. And for a person who has developed a methamphetamine use disorder, you really start like a normal day for somebody, you're like here, you're on this talk, you're listening to me drone on, right? Like, let's say your dopamine somewhere between 50 and 75, right? That's what a normal day is. For somebody with a meth use disorder, a normal day is like 20, and that's like your worst day. That may be like you are having a horrible, horrible day. Your grandma died. That's where you're at on your worst day. So people with meth use disorder are just maybe live at 15 or 10, and they're just trying to get to 20, which is the equivalent of your worst day, right? So I think it's really important to situate that. And and that's literally how I talk to patients about what they're like, I've heard this, does this resonate with you? And I get a lot of nods that yes, like that. What is the motivation around using methamphetamines, particularly in a pregnant and postpartum person? It's really just to get to functioning. Okay, so stimulant use in the United States, this is the orange, right, is significantly higher. And blue is not significantly different. I'm not so sure I totally believe this map, even though we're in the orange and the Dakotas are in the blue. My experience and what I have heard from people in the Dakotas and Montana is really there's high rates of methamphetamine use, and that's really the substance of abuse that people are using. So this is how it used to be, right? Like you can't do a talk about meth without Walter White in it. And we used to think about meth as being on the kind of a West Coast thing and fentanyl being an East Coast thing, and that people were cooking meth in these like campers, right? That's gone. It's not what we're doing anymore, right? We are in the super lab era. We're really using methamphetamine is now being produced in labs that are producing high potency, really high quality methamphetamines, which may then have maybe introduced, have fentanyl contaminated in that supply, either on purpose or incidentally. And what we've seen is really the history of super meth is that when we try to regulate in the United States and make things illegal, right? So like now when you go into Walgreens, you have to show your ID to get a bottle of Sudafed. Right. So like that was because of the, Walter White cooking in the camper. So like, just like drug policy in the United States, if we make it illegal, that usually cuts down on the supply, right? No, that's not what happened, right? So it really pushed This is an economic, billion-dollar industry. It pushed the supply into these super labs that are now producing P2P methamphetamine, super meth, and is appearing really everywhere in the country now. So, not necessarily talk, but just to remember that our drug policy really does change what we have available and what our supply is, and it can actually make things worse, right? And so this is what actually meth did. So it was actually more expensive to buy meth, and now we have much cheaper meth that is ubiquitously available and really starting to be ubiquitously available in the entire country. Right? So here more data to support that. So overdose pandemics, part of the reason, right, is you can consume meth in all of the holes that you have. You can consume meth using all of those holes, right? So it's important to remember that when we ask people, right, that there are more high risk or lower risk ways of using methamphetamine. So from a harm reduction perspective, smoking versus ingestion, those are ways that people are trying to reduce their risk. And I hear that all the time. Well, I used to use IV, but now I just smoke. And that really does impact some of that overdose risk. Okay, we're going to skip this. So why the overdose? Why are we in this overdose pandemic? So some of it is that there is fentanyl contamination in the methamphetamine. So really talking about fentanyl contamination when we address this as a public policy, public health campaigns, education campaigns for individuals to be aware that there is fentanyl, and there may be fentanyl in their supply. And I have patients who theoretically understand that there is fentanyl in their supply, but are like, well, I don't use fentanyl. And we're like, well, we just tested and you have fentanyl in your system, right? It's not that you use intentionally, and the flip side is also true. Like I have patients that just yesterday, I have a patient who is admitted in the hospital right now who came in who tested positive for cocaine. And she's like, I just smoke blues. Blues are what people call fentanyl pills. And she's like, I don't use cocaine. I was like, I'm not saying you use cocaine intentionally, but you have cocaine in your system. So it's really important to remember that it goes both ways. And 67% of the methamphetamine that was implicated in an overdose death tested positive for methamphetamine, but methamphetamine overdoses are independently increasing. And that is because of the lethality of the super meth that we have. So if people are really using meth for days and days on end, you can get exacerbating cardiovascular and pulmonary effects, so-called overamping, that really leads to circulatory collapse and death, right? So both directions. And those are really important things to discuss when we are talking about intervention. So this is a slide just around maternal death in Utah. We are so close to releasing our newest data, but has not yet been stamped of approval. So this is Utah data. Really, a quarter of our deaths were drug related in Utah from 2005 to 2014. It has gone up. It's really around 40 to 45%. And on these discussions with the MMRC, so last night I was on with the leaders of the maternal mortality review committees, and we're really seeing this, this is the ubiquitous story across the country, that this is becoming, so drug-related deaths and suicides are really becoming the leading cause across the country. And methamphetamines, in our data, about a quarter of the deaths were related to methamphetamines, and that has certainly increased since 2015. So we're really more like 30 to 40%. Opioids are still leading, but methamphetamines and really that co-use is potentially, with other things, a lethal combination. And the graph on the left is really to just drive home that point, that the 80% of these deaths are in that postpartum period, that 43 to 365 day period, compared to 34% of deaths from other causes. So that's really that lethal time for people with meth use disorder. And this is data that we presented that is now published with the SMFM and an AJOG in the Pink journal. The important thing here is if you combine opioid use disorder and methamphetamine use disorder, those individuals are 4 times more likely to experience a severe maternal morbidity event or death. And if they just have meth use disorder, they're twice as likely. And so just as a reminder, severe maternal morbidity, I mean, these are the really bad things, right? This is like, you had a stroke, you needed a cardiac catheterization. right? You had such a bad hemorrhage, you needed 4 units of blood. I mean, this is like you are knocking on death's door type of severe maternal morbidity or death. Okay, so we kind of talked about that, right? So this was the part where I usually talk about the orgasm part, but here you can remember that again and also situate that within how people experience methamphetamine. Okay, there we go. Again, my love language. Okay, just double checking on time. Okay, so time is part of the healing process for methamphetamine neurobiology, right? So a person without meth use disorder is the picture on the left. A person with meth use disorder with a month of abstinence is the middle picture, and a person who has been abstinent for 14 months. It looks a whole lot like the person all the way on the left, right? So it's really those dopamine receptors, right? The neurons that really are driving how we develop meth use disorder, but also how we heal from meth use disorder. It's all about time. And the longer that somebody has time under their belt, the more likely that they're going to be able to get to that normal, our normal day of 50 to 75 of dopamine in our brains. That's our normal day. And it's really around time and exposure. And then this is about overamping, which we're going to skip right now. Okay, so we're going to switch a little bit into medications for meth use disorder. Actually, I think we do have a little bit of time for overamping. So, as we talk about for PQCs, right, what we really want to do is prevent, right? Like the ultimate outcome we want to prevent is death, right? Like that is the ultimate outcome that is irreversible. I tell people this all the time, right? Like I cannot fix death. Like that, once we are there, we're right. That's the ultimate outcome. So in terms of overamping, it's really important to remember that over 80 people die per day of overdoses that include psychostimulants. And with overamping, what you want to recognize is that it's both physical and psychological symptoms. And once we're in that, at that point of somebody who's been awake for 3 days, right? They haven't eaten, they haven't had anything to drink. They are starting to have paranoia. They're starting to have altered perception of reality. They're really having trauma responses, psychosis. They're having physical symptoms of headache, nausea, vomiting, tachycardia, chest pain. They may have a seizure, shortness of breath. They have these stereotypic, coriform movements where if you come into an emergency room, so that my patient that I was talking about, she had a slightly different situation, but you can imagine a person who has had a bad experience, by the time they get to a hospital, right? They've been brought in, somebody is telling them to stop moving, but this is the process of overamping. It becomes such a fight or flight response that we have to understand this even in our emergency rooms and be able to provide the supportive treatment that an individual needs when they are overamping. And really those things there's nothing magical. It's, I think Justin Ellis is on here, it's that like you need a drink, you need to cool down, you need a safe place to sleep, you need a turkey sandwich, right? Like these are basic things that individuals need when they're in this situation. And really the misunderstanding of this physiological process also exacerbates these overdose events because people are so scared and don't want to go to the hospital where they can be helped. Okay, so I'm going to switch a little bit into medications for methamphetamine use disorder. I want to be so clear that this is so evidence informed. There is no evidence that this has not been really trialed in pregnant and postpartum people. So this is the ADAPT-2 trial where they looked at naltrexone 300 milligrams IM every 3 weeks and bupropion extended release orally up to 450 milligrams. In this study that was primarily men, there was a very modest response of not return to use, with 13% in the medication group and 2.5% in the placebo group. So overall, an 11% improvement. So that's not a lot, but it is a lot in an environment where we have very little to provide our individuals with methamphetamine use disorder. The other thing that and we counsel our pregnant and postpartum patients about this trial. So we say, we don't have data on pregnant or postpartum individuals, but you have to take it in relationship to what, right? If someone is using and they're in front of you and using methamphetamines during their pregnancy, which 99.999% of pregnant people recognize is not ideal, and they do not want to be doing that for both themselves and for their fetus. We talk about there is reassuring data with naltrexone that at least short-term outcomes in women with opioid use disorder look very similar to individuals with buprenorphine and methadone. So again, this is like not the same beast, that's opioid use disorder, but we use that data to really counsel individuals that naltrexone is probably safer than using meth during pregnancy, and bupropion is as well. And often individuals have co-occurring mental health conditions, and they are often using nicotine, and the bupropion is also indicated for depression and some anxiety and for nicotine use disorder. So you're getting a little bang for your buck here. Okay, so we talked about that's one of the interventions. So as we're switching over into care for pregnant and postpartum people, we really want to remember the principles of effective treatment, right? So these are the principles of effective treatment that we've already touched a little bit upon. That addiction is complex but treatable, and there's no single treatment that is appropriate for everybody, and we need to make treatment readily available for lots of people. And we should really be looking at this as a whole body, whole person approach, including families and communities. Okay, so harm reduction, harm reduction, harm reduction. This is so important. And I think PQCs are incredibly helpful in spreading the news that, right, it's not just about abstinence it is a goal if that is a person's goal, but harm reduction is the goal. We want to keep people alive, right? We cannot help people they cannot help themselves if they are dead. So we want outreach and education, and PQCs, like this is what we do, right, in PQCs. So needle exchange, really important, helps to reduce HIV and hepatitis C and other infections. I really need to update this slide and also say, right, syphilis is probably on this list now. We are certainly have a raging syphilis epidemic going here in Utah. And I think that's really across the country. Overdose prevention. So again, utilizing what routes do you use? If they're, willing to switch routes, having fentanyl. I like to always say with fentanyl strips, if somebody has not used one before, fentanyl strips were designed by a man, because every woman on the planet knows that 2 lines is positive and 1 line is negative, but is the opposite in fentanyl strips. Okay, so that is what I say. I'm like, okay, just remember, this is the opposite of a pregnancy test, and that is usually very effective in helping people remember how to interpret a fentanyl test strip. Access to Narcan, right, or naloxone. So essentially, I feel like everybody should have Narcan all the time. This is my, I will show you if I can pick up my backpack. No, it's now stuck on my chair. I was going to show you my Narcan that I have in my backpack that I carry around all the time. We should really just be, this is like sunscreen and seatbelts and speeding limits, right? Narcan should just be, we have the, AEDs in all of our public places, right? There should just be Narcan available all over the place, because we are in this overdose epidemic. You can't have a talk about meth use disorder without talking about child removal, right? You have to talk about this. The question that any person who is coming in with meth use disorder, who's pregnant or postpartum, is my baby going to get taken away? And the answer is maybe, right? Because that's our public policy around the use of substances when an individual is pregnant or parenting. So it's really important to address this right out, because that is the reason that people delay care, right? They delay care because they are afraid that their baby's going to get taken away. It is one, I've had people say, are the cops, when our care coordinator calls and, asks questions, or is telling our patients about what they can expect at our clinic, we've had people ask, are the cops going to be there waiting for me? Are you going to call the cops? These are the questions that people want to know, because that has been the experience of individuals. So it's so important to address to know what your mandated laws are, and to address that the way to avoid that from happening is to utilize all the resources that are available to get into recovery. But also, we don't want to blame the individual, right? We really have to, in a PQC, especially with PQCs, we have to think about our public policy, and we have to make recommendations to our state legislatures to change policies that make it our policies less away from punishment and more towards really being able to engage individuals, provide them with resources, provide them with residential treatment programs that they're able to have their children in. There are no programs, as far as I am aware, where a couple can be together, including in Utah. So, these are the things that we as PQCs can make recommendations to change policies, including ones around child removal. Right. And we also have to acknowledge that child removal is not equitable, right? So individuals who are white are much less likely to have their children removed than individuals who are from historically marginalized communities, including American Indian communities and Black communities. Okay, so integrated models, care models. So this is one of my heroes, Daisy Goodman. She's a midwife and has her doctorate in nursing, and she works up in New Hampshire. She published this great paper with her colleagues around how integrated care is really decreasing very important outcomes, including preterm birth. So integrated care is often a luxury. Integrated care means that the addiction and the perinatal care is happening in the same place. So this is a dream, but it is not the reality for most places. So it is often what we're trying to get to, but if it is not available in your community, which most of the time it's not, any care is better than no care. And when the care talks to each other, that's really the care processes that we're looking for. Can't have a talk about meth use disorder without talking about contingency management. So contingency management is really motivational incentives, often financial. There is consistent and strong evidence that in non-pregnant and in postpartum individuals that you see reduction in methamphetamine use and higher utilization of medical services and decreases in risky behaviors. The problem with contingency management is there are two problems. One, it's not covered by insurance. So it becomes usually a grant-funded thing that you end up writing grants for. And the second is that if you do have grants and they are from SAMHSA, that the amount of money that you need to actually have a dose effect is actually not possible. So there are restrictions on the amount of money that you're allowed to give. So those become the real barriers for an intervention that is very well studied and highly effective. Okay, we already talked about this and I apparently put it in two places. Okay, and this is other medications that have been used. And so I'm happy to share this but the other medication to bring up is mirtazapine. Again, this is certainly evidence informed and not evidence-based, but we absolutely have offered mirtazapine to our pregnant and postpartum individuals. And that has as a attempt to reduce consumption and potentially risky sexual behavior, which has been studied in men who have sex with men. Again, we talk about the risks and benefits, and we've seen some really modest effect in our pregnant and postpartum patients. Okay, so again, these are the two medications that are often helpful. Like if you look these up, right, there's going to say like use caution in pregnancy. Sure, use caution in pregnancy, but again, we have to remember that we're trying to prevent methamphetamine use, which we know can be lethal, right? So what in comparison to what? The other thing I didn't mention with naltrexone is that it does especially for individuals who really have a primary meth use disorder and aren't using a lot of opioids, if you can confirm that they're using that you don't have like fentanyl that's contaminated in their use, we offer the injection on site in our clinic, and it can really prevent overdose because it's an opioid antagonist. If they have meth, especially if fentanyl or opioids is not a substance of use that they use often, they are actually at the highest risk of suffering from an opioid overdose because they don't have the tolerance that somebody else has. So we've certainly talked to individuals who are like, listen, like I'm going to try, but I don't know if I can stop using, but we talk about this being a harm reduction strategy to prevent overdose. And we've certainly had individuals take us up on this from that perspective. Okay, and then I often get asked about what about stimulants, right? So what about stimulants in terms of using it for like Adderall or grade medical grade amphetamines, and really and I think I actually heard Justin, who's I saw on here, say like this is really peeing in the ocean, right? There might be some effect for cocaine, but when we're really talking about methamphetamine, the amount of methamphetamine, the amount of amphetamine that you would need to consume to really have like a methamphetamine medication for methamphetamine use disorder effect would kill you, right? So that's why this really hasn't been shown to be effective. Okay, and then another intervention is transcranial magnetic stimulation. This is this is using really magnets, like very fancy. They use magnets. They and they direct the signals at parts of our brain that affect addiction. And there have been studies looking at the control of symptoms and craving for meth use disorder in non-pregnant and postpartum people. We are starting to look at that here. I have a colleague in the psychiatry department who's really interested in this, and we're trying to see if we can get a study going for the use of, to really explore the use of this in pregnant and postpartum people. Okay, so we don't know what we don't know. We've got 43. I think I'm gonna get to the end soon. And we'll have time for questions. And then there's a lot that I didn't cover. So I'm sure you'll have questions about that. So this is the prompt trial that I was mentioning around progesterone. So we just, and oops, it didn't, we are no longer enrolling. We actually have closed enrollment because we got to our intended number. So we are randomizing postpartum individuals to micronized progesterone, 200 milligrams twice a day versus placebo. This is really a feasibility, safety, and preliminary efficacy trial funded by NIDA. And we've screened and consented 40 individuals, and 34 went on protocol. And so we are just finishing up the follow-up for this and hoping to see a signal and hoping that potentially we have something that we could study in a larger randomized trial at other sites to see if this could really be something that helps to utilize a very cheap intervention that allows people to prevent that return to use by stabilizing those parts of our brains that that trigger craving. Okay, we're going to sum it up. Substance use disorder is a chronic, treatable medical condition of the brain. Vocabulary and the words that we use are really, really, really important. And as a PQC, this is where you guys can really drive that and making sure that we're using the appropriate language. Stigma and discrimination really shows neurobiological changes, both in the victims and the perpetrators. We didn't talk about that much in this talk, but really the important part to remember is we have to address, as PQCs, we have to address stigma and discrimination. And part of the ways that we do that is by education and having and spreading this really important message that this is a chronic and treatable condition. And then we really need to understand the neurobiology of addiction and pregnancy to help frame the condition and understand that just because someone stops using in pregnancy doesn't mean they're cured, doesn't mean we're done, right? And it's really that postpartum period that we really need to be focusing our efforts on. So as a PQC, right, it's extending what are the interventions that we've really focused on in Utah. Some of the recommendations that we've made is extending Medicaid out to 12 months, but pregnancy Medicaid out to 12 months, really providing that extra support. In our clinic at the Super I Clinic, we don't even start talking about moving people onto different clinics until there are at least a year postpartum, because that overdose risk really does peak in that 6 to 9 month period, where oftentimes people have lost support. They've lost insurance. Having a 6 to 9 month old, if you've had a 6 to 9 month old or know people who have a 6 to 9 month old, that's when you're just getting real tired, right? It's real tired. Partner relationships are really peaking. That struggle is really there. The financial struggle is really there. So it's that perfect storm of time that we really need to focus on. Okay. We have time for questions.
Feel free to come off mute, turn on your camera, drop them in the chat. While we are,
I can look at you.
While we are doing questions, I'm just gonna drop a link in the chat for a survey. Dr. Smith is here through the Opioid Response Network, and they have asked us to share this. Sorry. So please complete this survey that is in the chat, and then come off of mute with any of your questions.
And I'm happy, I tried to focus because I think, I know this is a slightly different group, but, I probably don't say, you probably don't hear this often, but being in I got to come to South Dakota. I've never actually been to North Dakota, so I'm waiting for my invite. But it was, some of my favorite talks that I've given were in South Dakota. So I, maybe some overlap here. So I really focused on kind of the interventions. I didn't focus so much on like kind of prenatal and fetal effects, which I'm happy to talk about if there's interest to talk about that.
We've got a quiet group today. Yeah. Oh, yes, our annual meeting is September 30th and October 1st. You're welcome to come to North Dakota then. It's in Bismarck.
Okay, maybe.
Yeah.
Invite me to that party.
Yes.
No, and then also, I think this is an important topic, in the Dakotas. I know you guys struggle a lot with meth use disorder. And and here in Utah as well, I don't think my understanding is you guys don't have as much opioid use disorder as meth use disorder. And so I think that's why there's a lot of opioid money floating around these days, but really utilizing that and leveraging that to really address the substances that people are actually using in your communities. And there's a lot of lessons that can be learned from the opioid use disorder that can be translated over into meth use disorder, but it in and of itself is its own condition, and we can't translate everything. And so really the messaging is, do what you can with the tools that we have, and they're not perfect. But provide, I often tell people to like lean into, if this is a thing that has been used, or if somebody has been on something that's worked for them before, like lean into that, right? They say that this has worked, lean into it. And really the PQCs, I think, you have tremendous power and voice to the legislatures. The things that I think, we didn't focus a ton on, but really residential treatment programs, where people can have their children, and particularly older children. I think that's a huge barrier that we run into. Our 3 treatment programs that allow pregnant people to bring their older children cap at 12. So we've absolutely had individuals that say, like, I would go, but I can't because I have a 13-year-old. And where am I going to put my 13-year-old? No, you are not going to put my 13-year-old in foster care. I was in foster care, and that was a horrible experience for me. So we often get into, like, those are things that we talk to our legislatures about all the time. Like, those are not, you're asking people to make impossible choices. Not you individually, us collectively. All right.
Does anybody have any questions?
And it's okay. You can have 10 minutes back.
Yes, Dr. Smith, thank you so much. Oh, Jackie, did you have something?
Didn't have a question. I was just going to say that was a great presentation and really helpful information. That's it.
Thank you.
And come to Fargo, North Dakota anytime.
It's on my list. It's one of the few states I haven't been to. But I really, really love the I'm now trying to remember there's a at the airport in South Dakota. I realize you have multiple airports. I know that, but there is a really great shop that I spent a lot of money at the airport shop, because whoever buys the clothes for there knows me. So if that person is still there, I'll come back and go shopping and leave some money in South Dakota.
Oh, I love it. Amy said that this has been my brainchild for several years. Funding is badly needed for residential treatment where children are allowed, and life skills treatment. Yeah. North Dakota needs it.
Yeah,
and great
the info. Other huge hole that I don't know if anyone has is family treatment. right? Couples, like, I don't know of any, we certainly don't, we don't have resources for that, but if somebody's coming in as a couple, right? So we have an adult program where dads can go. We actually have a dad program here where I think we are still the only parents program west of the Mississippi that allows dads to be part of. So if you are a father and have a child, you can be part of that parents program. There's one, I think it's still the only one. I hope I'm wrong. If I am, please tell me. But if you are a couple, you have to separate, right? And some people just aren't willing and aren't able to do that. And we have no resources to be able to. So when I often say, you know, if we're going to call patients non-compliant, then we need to call our systems non-compliant, because our systems don't comply to what people need. So as much as patients are non-compliant, the system is much, much, much more non-compliant.
I like that. Thank you so much. Carrie, did you have something to say? I just saw you came off of mute.
My mind is reeling still, so I don't have a ton of concrete questions, but I was wondering where you got your chart about person-centered language. That was like way towards the beginning of your presentation, and if I could steal that.
Totally. And it's diction. If you Google diction of addiction, that will come up, but you can have it. Like, yes, you can, please feel free, take it. The other one is a dictionary. You put in a dictionary into Google, like all of those things. I mean, I like steal things from Google all the time, right? Like that's where those things come from. I think that one came from Sam. I think that one's the SAMHSA one. But it is, you know, that is a table that if you literally just put in that and go into the images part, that's where you find
Abby dropped it in the chat, a link for the dictionary. So thank you, Abby.
Thanks, Abby. Thanks everyone for your patience on the scheduling. I know I'm not an easy person to schedule with.
You are worth the wait. I so appreciate you working with our schedule and being here with us today. So thank you, Dr. Smith. Thank you to our other speakers today. And thank you everybody for blocking your time to be with us. We'll have this recording up on our website and hopefully by next week. But have a wonderful day. Thank you all so much for being here.
Thank you.